Hello, this is Amjad al-Mendilawi from Baghdad, Iraq, delivering a presentation on how to increase support for delivery of equipment during PCI. Part 1 will be about anchoring technique, where two cases are going to be presented. The first case is a 55-year-old male hypertensive and smoker with a stable angina, referred for PCI to LAD and circ. The RCA was normal. This is a epicodal view, shows a critical lesion in the proper left circumflex, then another lesion in a large OM. So basically, it's a tandem lesion in one large vessel from left circumflex to the OM. In the LAD, there is a plaque near the ostium with a mid-long calcified lesion. This is the epicranial view, shows the LAD lesion. There is a large septal branch arising from the lesion and some distal irregularities. So we started PCI as usual with balloon pre-dilatation using radial approach and guiding cath Jetkin left 6 3.5, the one that was available in the cath lab. Here stent positioning and stent inflation, post-dilatation, and a good final result for the LAD. Then we turned on to the left circumflex. Pre-dilatation was easy. This is the result after pre-dilatation. Stent could not be delivered. The angle with the left main stem is around 90 degrees, but that should not be a great problem if you have a good guide catheter support. At the second bend, there is a dissection that may also have contributed to difficulty in delivering a stent to the circ OM. So what to do? The lesion is dilated, but the stent could not be delivered. We have to increase the support, and this can be done by a large guiding cath. Having a French of 7 or 8 give a better support than 5 or 6. The shape of the guiding catheter is also important. An EBU for the left and an AL for the right give a better support. Femoral approach and the long femoral sheath may give a better support. Manipulation and deep engagement of the guiding cath is also useful, but this more can be used in the right coronary artery. Guide catheter extension, somewhat expensive. Body wire and body balloon is usually present in the cath lab, a stiff wire, or the anchoring technique. Now we talk about anchoring balloon technique. This could be either in a side branch, which is the most commonly used, or a distal anchoring, where the balloon is delivered over a second wire and inflated distally. The drawback of anchoring technique, especially in the side branch, it can be injured. Usually it's inconsequential when the side branch is small. And to reduce that drawback, you can use a small balloon with a low pressure, 4 to 8 atmosphere. Anchoring, usually when done in the side branch, it can be done in the conal or RV branch for RCA, in the OM for the circumflex, and the diagonal for the LAD. So in our case, we took advantage of having a stent in the LAD, passed a wire, and inflated a balloon. Here, there is no fear of having a vessel being injured due to higher pressure inflation because the stent already been inflated by high pressure. It's clear from this fluorosave that it provided a good support to pass the stent here from the left main to the left circumflex, then down to the OM. And this is the final result after additional stent for the ostium of the LAD. The second case is a 62-year-old male smoker, not diabetic, not hypertensive. Had a primary PCI for the left circumflex. The LAD had a long uncalcified lesion, so it was left for another session. This is the epicranial view shows a bend in the mid part of the LAD with a critical lesion, then another lesion distally. The diagonal is totally occluded. We failed to cross the diagonal, so we went on for stenting of the LAD, and we can see a stent in the circumflex. The LAD was pre-dilated. We can see a bend in the balloon at the mid part of the LAD. After dilatation, dissection is evident as expected. A stent could not be delivered to this LAD lesion. So further, multiple inflation was done with larger balloon 3 by 15 ANC and inflated to a higher pressure. Again, stent could not be delivered. It stopped at the bend. A body wire was not useful. Again, in this case, we took advantage of the stent being present in the circumflex. So this stent was implanted only 10 days ago. We used the same equipment for pre-dilatation of the LAD to do the anchoring. And here you can see the balloon is anchored to the stent in the circumflex, and it provided a good support, and the stent could be delivered to the LAD. Here the stent delivered distally. The same balloon was used for more dilatation. Another stent was used for the mid part. Again, it was difficult. And again, we used the same technique with anchoring to the circumflex. We reached the overlap situation. And this is the final result after balloon post-dilatation. So the messages are: calcification, bending, and dissection can hinder stent delivery. Proper lesion preparation is important. Anchoring is an affordable and useful technique to deliver stent in case of difficulty. And thank you.